Hello everyone, the last part of this class is drug treatment. The available antibiotics for CAP include the following categories: macrolide such as azithromycin, doxycycline, aminoglycoside, beta-lactam, beta-lactamase inhibitor, fluoroquinolones, and carbapenem. Since the etiology of CAP is rarely known at the onset of the treatment, initial therapy is usually empirical, designed to cover the most likely pathogens. In outpatient, the patient is healthy and no risk factors for drug-resistant streptococcus pneumonia. Macrolide or doxycycline is recommended. If suspected with macrolide-resistant streptococcus pneumonia, you can choose respiratory fluoroquinolones or beta-lactam plus a macrolide or doxycycline. For the hospitalized non-ICU patients, you can choose the following regimen. First, a respiratory fluoroquinolone. Second, a beta-lactam plus a macrolide or doxycycline. If penicillin allergic, respiratory fluoroquinolone or ertapenem is another option. For the patients in ICU, empiric treatment is a beta-lactam plus either azithromycin or a respiratory fluoroquinolone. For penicillin allergic patients, a respiratory fluoroquinolone and azithromycin is recommended. If Pseudomonas is a consideration, you can choose first anti-Pseudomonas beta-lactam plus either cipro or levofloxacin. Second, about beta-lactam plus aminoglycoside and azithromycin. Third, about beta-lactam plus aminoglycoside and an anti-pneumococcal fluoroquinolones. If penicillin allergic, substitute azithromycin for the beta-lactam. CAP treatment consensus include the risk assessment approach, early antibiotic selection, change treatment driven by local surveillance, hit hard and hit early, as short a duration as possible, de-escalate when and where possible. In addition to appropriate antimicrobial therapy, certain general considerations apply in dealing with CAP. Adequate hydration, oxygen therapy for hypoxemia, assisted ventilation when necessary are critical to successful treatment. Patients with severe CAP who remain hypotensive despite fluid resuscitation may have adrenal insufficiency and may respond to glucocorticoid treatment. Patients slow to respond to therapy should be re-evaluated at about day 3, sooner if their condition is worsening rather than simply not improving, and several possible scenarios should be considered. A number of non-infectious conditions mimic pneumonia, including pulmonary edema, embolism, carcinoma, radiation. This disease should be ruled out. If the patient truly had CAP and empiric treatment is aimed at the correct pathogen, lack of response may be explained in a number of ways. Pathogen resistant to the drug selected, sequestered focus blocking access of the antibiotics to the pathogen, such as complications, the lung abscess, and empyema. The patient may be getting the wrong drug or the correct drug at the wrong dose or frequency of administration. Another possibility is that CAP is the correct diagnosis, but an unsuspected pathogen is the cause. For prevention of CAP, vaccine targeting pneumococcal disease and influenza are a mainstay for preventing CAP. Reducing risk factors is another measure. Smoking is a significant risk factor for CAP, so smoking cessation should be attempted. In addition, stabilization of underlying conditions, for example, the congestive heart failure or diabetes mellitus, and the promotion of appropriate nutrition may help to reduce the risk of CAP and thereby promote longer and healthier lives. At the end of the class, I hope you can take home messages of the 6 steps for diagnosis and treatment of CAP. First, confirming the diagnosis and rule out non-infectious disease. Second, assessing severity and decide stage of care. Third, predicting the possible pathogens and the risk of drug resistance. Fourth, reasonably arrange etiological examination and initiate empirical anti-infection treatment in time. Fifth, dynamic evaluation of response to therapy. The last, follow-up and prevention. So that's all. Thank you for your attention.